Malaria epidemic detection and response. Learning objectives. By the end of this unit, the participants will be able to define malaria outbreak and epidemics, describe the purpose of malaria epidemic, forecasting and early warning, explain basic principle of malaria epidemic detection and responses. Definition. Outbreak is an increase in the number of cases of disease compared with the expected number. It lasts for a short period of time or occurs only in a limited area. Epidemics is an excess in the number of cases compared with the number expected. Epidemic is more general than an outbreak. The increase in the number of cases continues for longer and the cases are distributed across a wider area. Malaria epidemics is the occurrence in the number of malaria cases in excess of what is expected in a specific place and a period of time. Sometimes it is hard to distinguish malaria epidemics from the usual seasonal upsurge of malaria cases. Malaria epidemics can be one of the most serious infections. Epidemics could be an exaggerated seasonal or periodic increase of cases or explosive epidemics. An acceleration of a secular upward trend which could be related to neglect or breakdown of control measures. In non-epidemic areas, any transmission or even few confirmed cases can be considered as an epidemic. Rapid increase in the number of cases should be treated as potentially dangerous epidemic even if the number is within the expected level for a specific area and time period. Overview of malaria epidemics in Ethiopia. A devastating malaria epidemic is responsible for 3 million cases and 100,000 deaths. 150,000 deaths. Since 1958, major epidemics of malaria have been occurred at approximately 5 up to 8 year intervals. In 1998, a widespread severe malaria epidemic occurred in most highland as well as lowland areas of the country. In 2003, widespread epidemics of malaria has occurred in highland and highland fringe areas up to 2,300 meters. Causes of epidemics. Malaria epidemics can occur because of variability or changes in the rate of infection and population immunity. Epidemics can occur in places where there is low and unstable malaria transmission and where people have low or no immunity. Epidemics can occur in high transmission areas if there is deterioration of the health system, interruption of anti-malarial measures, migration of non-immune individuals in search of work. Malaria epidemics. Epidemic precipitating factors. Unusual local weather phenomenon and activities resulting in environmental modification that increase mosquito population. Increased vulnerability of population due to famine and malnutrition. Underutilization of anti-malaria interventions. Introduction of potent vectors. Resistance to anti-malarial medications and or insecticide used for vector control. Malaria epidemics forecasting and prevention. Predicting malaria epidemics from early warning signs could be possible by regular monitoring of epidemic precipitating factors. The occurrence of epidemic can be prevented by 1. Strengthening health promotion activities, implementing of effective preventive measures, strengthening surveillance and case detection system, strengthening anti-malarial commodities stock management system. Epidemic forecasting and early warning. 1. Epidemic forecasting refers to predictions based on seasonal climatological forecasts that are available within 2 to 4 months in advance. FEM and other sectors, DPPC, are responsible for achieving as well as monitoring this type of data. Early warning. This is a continuum of forecasting referring to more direct indicator of an impending epidemic. Meteorological data such as the amount of rainfall in a local area, flooding, an increase in environmental temperature, etc. Entomological data such as larval and adult mosquito density. Morbidity data, increased malaria cases at OPD, IPD, and inpatient disease, etc. Epidemic preparedness. Preparedness includes trained human resource, diagnostics, antimalarial drugs, supplies, and insecticides. Plan of epidemic preparedness. Identify vulnerable groups based on stratification data. Have capable-based stratification to allow flexibility in taking more targeted and timely interventions. Identify cables at risk of malaria epidemics. Have quantitative and qualitative information of the cable, including village mapping of epidemic risks and the local knowledge of the area. Review of previous epidemic records, 5 to 10 years epidemic data. Information on local epidemic risk factors such as meteorological, if possible, environmental, social, and economic risk factors. Information on biological factors such as parasite and vector species involved in the area. Then, regroup or stratify these identified villages and the population in their epidemic risks and further put them in sketch maps. As a rule, an additional 25% of the annual drug requirement should be kept as contingency. IRS and INS should be used in selected areas where substantial seasonal malaria transmission predictably occurs. IEC or BCC activities encouraging INS use, early treatment, seeking and acceptance, as well as cooperation of IRS operations successful. All regional health bureaus and world health offices should plan, request and budget the amount of contingency supplies required at each level. Should be part of the annual anti-malaria commodity microplan. All levels of the public health system should report at least monthly to higher levels the status of their inventories of critical supplies as well as expiry status. Epidemic detection and mitigation. Morbidity data monitoring. This data can be used for early detection of onset of epidemics only if data collection is complete, timely, or weekly reporting is appropriate, more representative, analysis is prompt, and interpretation provides as accurate indication of unfolding epidemics. Method 1. Epidemic detection. Method 1. Classic method. Use malaria surveillance monitoring charts. This is currently recommended and probably continue to be used for some time in areas of higher to moderate transmission. Method 2. Method 2. Cluster or mapping. Method 2. Cluster or map. Method 2. Cluster mapping will be applicable as malaria incidence and transmission in an area fell to low level. This method will improve management of the relatively few clusters of malaria infection that remain within communities. Method 1. Malaria epidemic is defined as the occurrence in a health facility catchment area of cases of an illness clearly in excess of normal expectancy. Method 1. To establish a threshold norm chart of any given year, a health facility past 5 years data should be compared by week. A threshold determined using the two largest number. The current year data should be compared with the threshold. If an increase above the weekly threshold is observed, it implies that there may be an epidemic. Definition involves clear time, place, and person. For this, we need to know where, which health facility catchment or other defined area are affected, when, at what time period the epidemic has occurred, what is the normal expectancy of data are, and time period. What do we mean by cases? Case definition. How many of these and what proportion of tested cases have malaria by heredity or microscopy? What is regarded as excess? Who has become ill? Health post or Kabbalah is the smallest administration unit. PHCU can use disaggregated data by Kabbalah or health post. Time period. Where the health of WHO week, Monday up to Sunday. The threshold can be established the options. If you have previous 5 years data, use the second largest number or the third quartile. The norm chart or threshold. What is necessary to build malaria monitoring chart? Ready-made malaria monitoring chart. 5 years data of Kabbalah or health center disaggregated catchment area. If there is no 5 years data, doubling of the last year's data. If there is no last year's data, use recent weeks collected data. Whereas should use disaggregated data of the health post or Kabbalah and health centers and draw their norm chart or threshold. Why do we need a threshold? It can be very difficult to distinguish an epidemic from a normal seasonal increase of cases. Once it is apparent that the seasonal case increase is much higher than the normal, the epidemic is well underway. How to calculate the threshold? The following tables give example of how to tabulate the data for establishing a threshold. This is the table. Table 1. Chart for assessing annual number of weekly cases, confirmed or critical and threshold at healthy facility. This is second chart. Key principle of epidemic detection and action. Defining epidemics according to a particular time period and areas. The basic unit of time is a week. Epidemics in method 1 is defined according to a weekly threshold, while method 2 uses a time window of up to 4 weeks. In both cases, taking actions to avert the epidemic should be as soon as it is detected. Key principles. Both methods use a combination of active surveillance and other containment actions. LLINS use other vector control, requesting supplies and further support if need arises. Method 2 provides an evidence basis of our SCBCC efforts and other resources focused on areas of the Kabbalah with the most intense recent malaria transmission. That means malaria microcluster within 1 kilometer. There is no need to wait for formal confirmation of an epidemic before starting active surveillance and containment actions. Epidemics which spread beyond the Kabbalah or Warada may need further support and confirmation from zonal, regional, and national levels to provide additional resource supplies. Epidemic confirmation can be confirmed with RT or microscopy. Large epidemics will require blood slides for microscopic examination and analysis by Federal Ministry of Health or EPHI experts. In certain cases, dried blood spots on filter paper may be collected for serological analysis. Initially, the most important information needed for an assessment will be how many suspected malaria cases or persons were documented within a specified time period, which means within a specific district or Kabale place. How many of these suspected cases were tested by radiator microscopy? How many of the tested suspected cases were diagnosed as positive for malaria? How many laboratory confirmed malaria cases were PF or how many were PV? Analyze mobility data by place, person, and time. Calculate CFR, an increase in suggested drug resistance or decline in quality of care. Estimate the burden of malaria cases. Example, number of cases, percent of OPD visits, proportion of affected population. How many were severe malaria case, hospitalization and deaths? Compare current malaria case with the previous year data. Is there adequate supplies for RDT, AL, chloroquine, quinine, rectal artesunate, IV, artesunate, and other antimalarial drugs and the supplies? List of persons tested and treated during mass precipitative fever treatment, MEPRT, or mass fever testing and treatment, MEFTT, must be reported. The following table may be used for recording MEPFT or MEFTT, starting from 1 randomly selected household in highly affected part of village. Take 20 houses in sequence and fill in the following format. Response to malaria epidemics. Measures for control of malaria epidemics would be selected on the basis of epidemiological situation of the area, characteristic of the epidemics, availability of the resource. Response to malaria epidemics. Mass fever testing and treatment. MEFTT. Test everyone with fever and treat those with confirmed malaria. These steps should be taken when sufficient therapies are in stock and as long as heredity positivity is less than 50% upon examination of 50 febrile patients. Treatment must be specific, refer to figure. Heredity severe tolerance was of the most vital medication. AL, since test negative patients do not need to take AL.